targeting bacteria, because the principles of chemotherapy means they have to be selectivity, that a molecule will choose to target one cell and leave the other intact. And that's the principle of chemotherapy, right? So I would like us, or maybe I'd like you to tell us what cells such that molecules can target them, kill them, and leave the human cell intact.
Of course, when we are targeting the pathogen cells, remember the antimicrobials have different mechanisms of attacking the pathogens, and these cells have receptors. They have their own components on how they function. So what I can say is that the antimicrobials, they target specific aspects of the cells that can destroy the cell and make the organisms, like we've talked about, like in penicillin, talk about the cell wall synthesis. So the penicillins are able to inhibit the process of the cell wall, and then the
cell
bacteria
wall,
is able.
all right, so it means we can target specific structures, right?
Yes.
Good. Boaz Onchari.
Yes.
Are you with us?
Yes.
So other than targeting cell structures, what else is can be targeted?
You can target the DNA or the replicating mechanisms of these microorganisms, which
Those are
yes.
Those are cell structures, right?
Yes.
Anything else? Drusilla. I'm looking for something specific. Yes, Drusilla.
Yes.
What else can you target?
I think can target the pathways in which the cell follows.
Thank you. You can target certain biochemical pathways, right? For example, we know cotrimoxazole will tamper with folate metabolism. It means then the bacteria cannot produce DNA normally, so it will basically stop multiplying, right? So we can target either structures or biochemical pathways, right? And for biochemical pathways, we'll target the folate pathway, right, mostly. Then for structures, either the cell wall, or we can target the ribosomes. We've talked about the aminoglycosides and chloramphenicol and such like molecules. Also, we can target, other than targeting translation at the ribosome, we can target the actual DNA replication. So that when a bacteria is trying to make a replica, because we know how do bacteria replicate? They do that by binary fission. Like when a bacteria is mature, it replicates DNA to form a daughter cell. Okay, so that the daughter cell can have exact genes like the mother, or in case of resistance, then the new genes can be transferred to the daughter cell. That's very important for bacterial survival. So then it means also that as we expose these microbes to suboptimal levels of these drugs, then they can learn to survive and thrive in presence of these antibiotics. So we shall talk about fluoroquinolones, and when I left school, there's so many caveats on fluoroquinolones. And Tiptoe, who is that? Pauline?
Yes, sorry, my device is having an issue. I'm answering using another person's phone.
No, you may have to mute, okay? You don't
Yes.
want instructions. Now, so then you see this one has taken off, has taken away our attention. So we talked about chloramphenicol and its early use in targeting gram-negative aerobes and anaerobes. And it was largely replaced by fluoroquinolones. However, fluoroquinolones have their own side effects, and there are many, not as many as chloramphenicol though. But the problem with fluoroquinolones is that some of their side effects are long-lasting. They can last for a lifetime. They're life-changing. They can be fatal. So because of that, then their use has to be restricted. Okay? So based on that, fluoroquinolones will be considered second-line drugs. Okay? And I remember talking about aware classification. So where do you think we shall place fluoroquinolones? Just from my introduction.
I think you can place them under the watch drugs.
This should be placed under the watch for A, the side effects, B, emerging resistance, so that we reserve them if the access drugs fail. So I want us to focus, because I want us to watch just a video. You know, when you watch something, you're not likely to really forget a lot. So I'll go right ahead and share my screen. You can see my screen?
Yes.
Yes.
Good. You just listen, okay? Just listen. It's a very short video.
There's no sound in the video.
Excuse me, Doctor, there's no sound. Excuse me, sir, there's no sound.
Are we following?
We can't hear anything.
You cannot hear anything? Okay, can you see?
The video is visible, but there's no sound.
Oh, how comes there's no sound? You can just follow the video, but there's no sound. Okay, I don't know. I don't know what happened.
Yes, the video is just playing, but there's no sound.
My sound is at maximum.
You can check whether you consented the sound also to be shared during your sharing of the screen.
I think there's some settings, right?
Because you can share the video only and not share the sound, and vice versa.
So at the video settings here, right? So I don't know. Any of you know how to do this troubleshooting?
Probably you can check at your settings when you're sharing your screen, whether you had allowed the sound from when you're sharing your screen in Kenneth.
That's why I think I prefer Google Meet. This one is a bit. Is it you can hear it now? Can you hear? Did you hear anything?
No.
No.
Not yet. If it doesn't work, then we just go direct to the lecture. This one? So not yet, right?
Not yet. You can just share the link for the
Share the
video.
link.
You can watch it.
Okay.
Yeah.
I can just share the link after because I'll just share after the lecture, okay? All right. I hope you can see.
Yes.
We just go directly later. It's quite informative and it will make you retain. So these compounds are basically quinolones, and they're called fluoro because of addition of fluoride group. And we know why that halogenation is necessary. So we've learned in the past how most of the antibiotics were discovered by accident, and this is one of the important lab accidents. And I hope we have more accidents going forward. Now, so the earlier quinolones were used in management of UTIs. That's true even for now. When we learn about UTIs, we learn that especially first, second generation fluoroquinolones are usually applied in management of UTIs. So fluorination came so that there's better penetration. Remember, these molecules work intracellularly, so they just have to pass through the cell membrane in necessary amounts to cause cellular damage to the prokaryotic cells. So this is the mother of all fluoroquinolones. And going forward now, because of modification of this ring, okay, so halogenation and adding bulky groups on this position means there's better cell penetration. The very first one and the common molecule we come across is ciprofloxacin, right? Then we have other like third generation like moxifloxacin, usually important in management of gram-negative anaerobes, especially if somebody's having conditions that require surgery, abdominal surgery. Moxifloxacin is important also in management of resistant pulmonary TB. Levofloxacin, ciprofloxacin have almost similar use, right? And then for the others, there are newer molecules, and at the end, now we have newer fluoroquinolones that are yet to enter the Kenyan market. But I'm sure by the time you enter practice, you shall encounter them. The older ones maybe will have been phased out. So they're bactericidal. And I know we can list bactericidal agents. We can also list bactericidal agents. So they usually block DNA synthesis by inhibiting DNA gyrase and topoisomerase 4. Now, these ones work in tandem because when the cell wants to make a daughter cell, it has to unravel its circular DNA. And during unraveling of DNA, imagine somebody trying to unplait hair, right? So there is supercoiling, either negative, positive supercoiling. So we usually have what you call type 2 enzymes. There are so many of them, but the most important one is we have topoisomerase 1 and 2 and 3. For the sake of discussion in relation to prokaryotic cells or the bacteria likely to harm us, we're lucky that they have DNA gyrase. This one is also called topoisomerase 2. So this works to unravel or unwind. Rather, when the helicase is unwinding because of supercoiling, is something called a DNA gyrase, which usually attaches and stabilizes the DNA so that the uncoiling is stopped, right? So it means when you stop the uncoiling, the efficiency of replication is high, right? So this is where fluoroquinolones come in, because they usually bind not necessarily to the DNA gyrase, but to the DNA gyrase and the DNA complex. Okay, so it stops that repair of the supercoiling, and that causes the cell to stop reproducing, and usually it breaks, right? So for topoisomerase 4, after completion of the, as the unraveling happens, then there's a sister complementary DNA that is formed. So topoisomerase usually makes sure the separation between the two sets of DNAs, right? So that's where now also fluoroquinolones will bind to that enzyme to stop that split. The effect is the same for effect on DNA gyrase and also for topoisomerase 4, right? But for topoisomerase 4, topoisomerase 2 important in gram negative. So that's the summary of how fluoroquinolones are supposed to work. Now, how do they access the cytoplasm? They usually enter through porins, which are usually pores through which substances enter freely in and out of the cell. And you've talked about resistance. You expect that this topoisomerase 2, topoisomerase 4 will not take things lying down. So they will have to develop mechanisms by which the molecule can no longer bind due to steric hindrance. And because of that, there's a lot of growing resistance against fluoroquinolones. Also, because we've talked about them entering through porins, then there will be changes in the porin such that anytime a molecule wants to pass through, it cannot, because of addition of some bulky groups on those pores. The problem with resistance, then you may not respond to a third, fourth generation cephalosporin, rather fluoroquinolone, and that's a big problem. So how do we classify these drugs? We've talked about the first generation ones. These ones UTIs and also food poisoning. Okay, it's important, especially in dysentery. And most of the these drugs, especially first, second generation, you can actually use them as second line for conditions like dysentery. So nalidixic acid could only target gram negative. So that means it could target which enzyme of the two enzymes I've talked about. So it will bind to topoisomerase 2. Then now we have norfloxacin. This one usually nowadays we use it a lot for mostly food poisoning or for UTIs and some gram-positive Staph aureus. So now we have resistance against especially MRSA. Ciprofloxacin, like 10 years, you're counting 10 years from now back, we've used a lot of ciprofloxacin. It has really saved a lot of lives. However, now we don't recommend the use of ciprofloxacin as a first line in any situation because of things or side effects that we shall talk about. Right, ofloxacin also a lot for UTIs. I'm yet to see an oxacin in the Kenyan market. Then also the difference between second, third is that third generation will have extended gram negative, atypical, and also it covers atypical bacteria. And I keep on reminding ourselves that atypical bacteria is quite difficult to treat, and if we don't know the right molecule to use, then they usually kill quite fast. So that's why I keep us reminding ourselves that we should know the options. For instance, if we can't access, or if, because we've said this drug should be reserved drugs, which are the options we have before we decide to choose fluoroquinolones for atypical bacteria? Faith. We have Faith Oyego?
Yes.
Yes. So if we, because we can't use these drugs as first line, which other options do we have for atypical bacteria? Are you there?
I'm not sure.
You're not sure?
I'm not sure.
I think I talk about this thing almost all the time. Who is Ndanu? Ndanu is logged out. Koech. Bernard.
Yes.
So for atypical bacteria, what are the options?
I think we can also go for macrolides.
What did you say?
Macrolides.
Macrolides. What's the cellular target for macrolides? Bernard.
Yes.
What's the cellular target for macrolides? Yes? Anyway, Millicent?
Yes.
Yes. Atypical bacteria.
We can use tetracyclines.
We can use tetracyclines, right? Good. What else? Ndege, Washira. Well, this and some of you just logged in. The good thing with Knet, it will tell me those of you logged in and you are and logged out. So class rep, I'll have to send you the data because you're doing a cut next week, and I'm seeing people here will not do that cut. Timothy Kagevera.
Yes.
Yes. Other than she said tetracyclines. What else?
Aminoglycosides.
aminoglycosides, right?
Yes.
Right. Brittany, what else?
I think even the fluoroquinolones.
No, we've said other than fluoroquinolones.
The macrolides.
You can use macrolides. They're not very effective, right? And I think I've talked about this thing not once, not twice. So, Brittany, what's special about atypical bacteria? Can you hear me?
Yes, I can.
Oh, okay. What's special about atypical bacteria?
I think they lack the peptidoglycan cell wall.
They don't have a cell wall, right? They lack basic structures that can make something to be described as a bacteria. Okay, and also because of that they're quite small. Okay, some have the size of the big viruses. So what's the pharmacokinetics? Most of them will be absorbed orally. Their oral bioavailability approaches that of when they're given parenterally. Half-life 3 to 10 hours. We shall talk about specific ones. Oral absorption will be impaired by divalent cations. So this is also a precaution we take with which other antibiotics? Which other antibiotics? With tetracyclines, okay? So when you give somebody has come with severe GE and you decide to give them ciprofloxacin, right? So what do you tell this? What are you going to tell this patient? Simiu, Samuel.
Yes.
So any dispensing notes for these patients?
You said the patient with severe GE and?
No, you've already decided to give them a fluoroquinolone. So knowing the interaction, what will you tell them? They should
Milk.
with any dairy product, right? And which other drugs? What about drugs? Pardon? So where are you likely to find magnesium or calcium or aluminum? Which drugs contain this?
Antacids.
Yes, exactly. So most of them are renally excreted, and it means then if the creatinine clearance is below 50 ml per minute, then there will be necessary dose adjustments. Perfloxacin, moxifloxacin metabolize primarily the liver, and they have limited CSF penetration, but all the same, they can penetrate CSF more than many drugs. So this is how they'll be distributed. For these organs, it means then the concentration is higher than the concentration in serum. So they partition more into these parts of the body, partition less into these parts of the body relative to the concentration in plasma. So then it means they're important in treatment of infections that affect these parts of the body. So don't talk about stool because that's not target. It means then after metabolism, they'll be eliminated through stool. Then the drugs that will increase amount of fluoroquinolones in plasma, theophylline. We use theophylline, or it was used a lot in asthma. NSAIDs are also corticosteroids. Then those ones that will increase fluoroquinolone will increase the concentrations of antidepressant, imipramine, caffeine, theophylline. It means these are CYP level interactions, right? Then these are the general indications that we shall talk about. Of importance is that we use these drugs a lot in osteomyelitis, and because we know when bones get infection because of poor bone penetration of many drugs, then if we can't use clindamycin, then we can use, or we can't use third generation cephalosporins, then we can use fluoroquinolones, and they usually, after long-term treatment, they can heal. But then there's a caveat to this because then we know tendon rupture and tendinopathy. So now you can see why it should be used when there's no any other alternative, because you can heal the bone. Then if somebody will have tendinopathy, then I think you choose one evil over another. So there are the general side effects. You shall read about the specific side effects. But generally, you have nausea, vomiting. But I know if I'll ask you about side effects, you start with nausea and vomiting. Should you get a point? Should you get a mark?
No.
You shouldn't. You can't go to Kempinski and ask for what? For some Ideri, right? That's one you could have gotten it elsewhere. So I expect this from nursing students, right? For CNS, this is important. When you give a patient, especially long-term treatment, if you're treating osteomyelitis, make sure you know their status, the CNS status. So these drugs will cause confusion and insomnia and dizziness. Just know how to manage their conditions. Then also anxiety and seizure, especially moxifloxacin, can cause seizure. So it has to be really, it's a contraindication for patients that have seizure conditions. Okay, because it displaces GABA, and GABA has to bind to its GABA A receptor to ensure there's chloride influx, so there's no hyperexcitability, right? Then for CVS, okay, almost all fluoroquinolones will cause a QT prolongation. I know we've done physiology, we know about the ECG. Damage, cartilage damage. I've already talked about tendon rupture and tendinopathy, right? After long-term use, it may not be reversible, right? So then for athletes, especially people who do physical activity, it means you really have to avoid giving them these drugs. When people who depend on their physical, strength to feed their families. So you really try and avoid fluoroquinolones. right? So also phototoxicity, which other antibiotics have that side effect? Yes, which other antibiotic will have phototoxicity as a side effect?
Aminoglycosides.
Aminoglycosides.
Tetracyclines.
It's actually tetracyclines. Aminoglycosides are usually known for causing things like deafness, right? True. Now, leukopenia, eosinophilia. Now, when we talked about these, drugs targeting certain unique targets in the cell relative to those in the human cell, it's not really exclusive. Okay. Now, I've talked about topoisomeresis, right? It's not that we don't have topoisomeresis. Human cells usually have topoisomeresis too. And their role is basically the same, to make sure there's efficient replication in cells during mitosis. The only advantage is that during evolution, okay, the bacterial topoisomeresis grew more complex. Human topoisomeresis grew more simpler. Okay, so for theirs they have to be tetratymers, right? So they work in 4 hours, work in 2s. And the good thing about the bacterial topoisomerase is that it has exposed acidic parts with which these drugs form stable bonds so that they can be inhibited. For ours, the drug cannot technically inhibit our topoisomerase because of its structural difference. And so at normal clinical doses, you don't expect these things to happen. But at high clinically, rather in the lab, it has been shown that even human topoisomerase can be inhibited. But then at extremely high doses of this drug. So that gives it the selectivity for bacterial topoisomerase, and it means that we can use these drugs safely. However, it's not it's not true that it cannot interact with human topoisomerase. So you expect that after prolonged use, then there can be seen some blood changes showing that these drugs can affect cell replication. So you expect, in very rare instances, people to have leukopenia, eosinophilia. And liver, then rarely you'll have increased transaminase levels. Then hypoglycemia, also hyperglycemia. You can have both. In some people, in some people, hypoglycemia, and those are things that cannot be explained. All right. Now, so these are the contraindications for children. I know when I finished my undergraduate, I was told never give it to anybody below 18. But you realize at some point, if dysentery is not responding to access drugs, then you can give a 3-day course, okay, like 250 milligrams for children for 3 days. It's not appropriate because you expect then child's development will be affected, right? Lactation, Also in epilepsy, we talked about CNS side effects and also QT prolongation. So you also have to know other drugs that can cause QT prolongation. It means that they should not be co-administered with these drugs. Now, these are the specific drugs, right? And I've done a summary of their uses, their doses. Also for moxifloxacin. But I also want you to go read about these new drugs. Now, these drugs are FDA approved, or the European Medical Agency has approved them for use. The good thing is they have shown that for resistance to earlier tetrafluoroquinolones, rather, these drugs can actually treat such early resistance patterns. So it's actually good news, and I expect them to enter our market pretty soon. Right. So other than targeting topoisomerase 2, now we have also topoisomerase 1, which is also now there are drugs being developed that can target topoisomerase 1. It means then for resistance to the common fluoroquinolones, other drugs targeting topoisomerase 1 will come to the rescue. So we have also novel bacterial topoisomerase inhibitors. Just make sure you know what are these novel bacterial topoisomerase inhibitors are and how different are they from the typical fluoroquinolones that we'll encounter or that we know about, right? Then also something I also want you to know is that because these drugs were prescribed and overused over time, they've now been moved to watch section of the antibiotics. And in your hospitals, when you'll be doing antimicrobial stewardship, just make sure that all the healthcare workers are aware of that, and there should be stricter controls on this. How will these drugs be prescribed in hospitals where there's serious stewardship? Or these drugs will not be prescribed unless the prescriber will have to justify why they want to use it. And I've talked about their side effects, especially after prolonged use, having a permanency. And because of that, then we just don't have to give them anyhowly, especially to athletes or people doing physical activities. Another side effect that you have to be aware of because of that effect on connective tissue, then you expect them to have patients can develop aortic aneurysm. Okay, so the CVS condition has to be really monitored closely because, as I've told you, these drugs they have to be used especially for TB, which is MDR TB or XDR TB. Fluoroquinolones cannot be avoided. So these patients have to be really monitored, especially the CNS effects, CVS effects in relation to aneurysm in the aorta or the arrhythmias because of the QT prolongation. What about diabetics? What do you think should happen to diabetics? What should happen to diabetics? Charlotte? Charlotte is with us? Masai?
Hello, yes.
Yes. What about diabetics? Can we say we can never give them these drugs?
I think we can just monitor because we can just monitor depending on the glucose levels.
Yeah, it means then they have to be given, but they have to be told these drugs can affect the sugar levels, right?
Yes.
Then another point we have to know is that these drugs will cause peripheral neuropathy. Which other drugs do we know that can cause peripheral neuropathy? I know we know for sure. Which drugs?
We have rifampicin.
Rifampicin can cause peripheral neuropathy, right? And the problem with peripheral neuropathy with fluoroquinolones is that it starts quite quickly and it can be permanent, right? So how do you manage peripheral neuropathy? How do you manage that? And what will the patient tell you? What will they feel?
These patients present with tingling pain or numbness in their extremities. So, so they are managed by giving them B complex. You can give them a B complex or vitamin B6.
You basically give them pyridoxine, right? And if they're not responding to pyridoxine, because many times the patients may not respond to pyridoxine. So what do you do?
You can give pregabalin.
Somebody has talked about TCAs, right? Tricyclic antidepressants. Usually TCAs work, they work quite well. The problem with TCAs or pregabalin is the side effects are quite a lot, and patients will be, for the entire time of treatment, they won't be very productive, okay? But then it means we just have to know if a patient is developing this, what do you sacrifice? Do you go, we're doing these drugs because we don't have another option. So then it means we just have to have a contingency measure on how to manage side effects as a result of these drugs. Okay, that's very critical for pharmacists. You need to know if you enter some hole, how do you get out? Of course, using science, you can just reverse these things, and that's the beauty of you knowing a lot about drugs, and many people out there will depend on you to to help them in such scenarios, right? So I think we come to the end. I'll have to share that link, but then you can just go to YouTube and look at it. I want to welcome questions because it's still our time before we end this lecture. So ni wakati wa maswali. Yes, Timothy.
Yes, there is what we call an H. pylori kit. It mostly consists of, let's say, amoxicillin, clarithromycin, and let's say a PPI. But then there's a certain brand, which I don't want to mention the name, has included a fluoroquinolone, a PPI, and then with zinc in that H. pylori kit. And they're selling, that brand is really selling. So what is the concern of combining fluoroquinolone and zinc in that H. pylori kit?
So first of all, there's a lot of misuse of H. pylori kits, and we know Helicobacter especially in African populations where we eat a lot of street foods and kachumbari, and you eat somewhere, drink water, the way they don't really clean their kitchenware so well. So there's a lot of assumption that we have, but we also know that H. pylori can be there, may not cause, most of the time it may not cause the, being part of normal flora, it will not cause the ulcers. Until you get an ulceration, then a test has to be done, H. pylori test, mostly through stool or endoscopy. And, it will be seen under microscope, then you'll have to be treated. But then we have the first line kits, right? We have the first line kits, and the first line kits usually used to consist of amoxicillin, clindamycin, and a PPI. And now people are more usually that one, or you can replace clindamycin with another drug that is active against gram-negative iron, like metronidazole. So when that fails, then now we have the kits that contain fluoroquinolones, right? So your question is about zinc. Now, when fluoroquinolones are binding to topoisomerase 2, they need what you call bridges. Okay. So zinc usually has the binding ability of fluoroquinolones to that zinc bridge. Okay. Why is this? Why is this? Are you with me?
Yes.
Yeah. So
the concern was.
Yeah.
The concern was because you've mentioned they have similar interactions with divalent metals. For example, we've talked of those drugs like antacids containing metals like aluminium, and also zinc is a divalent metal. So are we expecting also an interaction with fluoroquinolone with zinc because it's a divalent metal?
If there's a co-formulation, right, then the co-formulation be made in a way that whatever amount that will be not be absorbed, right, will be covered by the increased affinity of that drug to the enzyme. Understand? Such that if you do area under a curve, it will be the same, but then the compensation will be how fast or how much or how fast the enzyme can be inhibited.
Okay.
Yeah. Another question?
Can you comment? I've heard some guys say in the market that fluoroquinolones respond very well, or they're more when tubular or luminal infections as compared to non-luminal infections, and therefore you should give it a priority, especially the second generation, as compared to if maybe compared like other like penicillins or aminoglycoside or macrolides. So I want just to see if that kind of thinking makes sense.
For luminal infections, I talked about like right now, we see increased use of these drugs for like severe gastroenteritis, right? But then you have to restrict these drugs to severe infections rather than mild infections. Okay, so it's not totally justified to use these drugs for mild, where we have other options. Okay, we can only use, for example, if gastroenteritis is so severe, then you're justified to start a patient on IV fluoroquinolone, right? then followed by oral fluoroquinolones. So yes, they are very effective in management of luminal infections, also systemic. But then from what we've discussed today, don't go for that option because we have other options. True?
Yes.
We do. So we should reserve. The reason why drugs should be reserved is not that they're not working, but it's that they should work when the other option is not working. True.
Yes.
You'll not be surprised that you'll go to a hospital for a simple gastrointestinal infection and you'll get linezolid, a fourth option. True. Definitely it works, but it's not necessary. Right? Julius, are you there?
Yeah, it's right. Yeah, but in government, I think in government hospitals they are very keen in these principles. But in our private hospitals, I just see guys prescribing these antibiotics left and right without necessarily following the case.
Some of you will be chief pharmacists in private hospitals, and I usually have a big problem with private hospitals because, especially if you have medical insurance, the aim is to get money. They'll do anything. You can go there for headache and they'll do PCR, right? So it's just there's no medical science between in what many private hospitals do, other than them trying to increase their profitability. So it will be like a target. Like you have to hit a certain target at the end of this month. There's literally no scientific basis behind what most of the things they actually do, right? Unless you know your rights, you can really restrict them, okay? But then you won't be their best fan, and they may not be very willing to receive you next time. But in public hospitals, for sure, yeah, there's very good stewardship, but also I have to tell you that some private hospitals like Gertrude's, Empisha, where stewardship is good and pharmacists are having leading laurels, I have to tell you that they take these things quite seriously now.
Thank you.
Yeah. Yeah, Swali, where are the ladies? So we are good. Now we have to prepare for CAT next week, such a time before you break for your holiday. So I'll have to send the notes later if necessary. But if not, then you'll have to, because you've been attending class, I think we'll do it without even us sending the notes. So get ready for CAT next week. Thank you and enjoy. Yes, Samuel.
Is it possible to have the cut in January because we have other cuts next week?
How many cuts are you having next week?
3. They're quite bulky. Yes, kindly.
So what's the consensus of the class? I think, what is the class rep? I think you're the class that has the highest turnover of class reps. Where is the class rep? The current one.
I'm present.
Newton. So what's your expected half-life?
We can have it in January.
I'm asking, what's your expected half-life as a class rep?
I'm not sure.
There are too many coups. You guys, are you living in West Africa?
So we want everybody to have an opportunity.
All the best. But then I need some stability. Okay.
Okay.
All right, then let's agree then to have it in early January. I think when we come back. Is that okay?
That's okay.
That's okay. I also want to know if you've been taught about antifungals.
Yeah, we are currently doing them in another unit in pharmacology.
By Dr. Irene.
Irene. Yeah.
All right then. Okay. Enjoy your time.